I have the chat box open on my second screen too, so I can kind of keep an eye on that, but
And I'll be monitoring it as well if there anything comes up that I'll be needed for as well. So feel free to message me if needed.
Good. Yeah, I'll just ignore anything that says I can't hear you since I can do nothing about that.
Alrighty, everyone. My name is Joe Stratman. I'll be moderating this session. This is IC 46, Dynamic Seating, Diverse Applications, a series of case studies. We have 3 great presenters that will be talking today. So keep in mind to keep everybody's mics muted. I will give the CEU code out at the end, and I will also provide it in the chat box. So without further ado, I'll turn it over to you guys.
Thank you, Joseph. Appreciate it. And welcome, everyone. Thanks for joining us today for this virtual session. And we do hope that it's really helpful to you and to the clients that you're working with. So let's get started. So there are 3 of us, and we're each going to be sharing a case study. My name is Michelle Lange. I'm an occupational therapist in the Denver, Colorado area, and I have a lot of clients who benefit from dynamic seating. So it's an area that I really enjoy working in. Missy?
Hi, I'm Missy Ball. Thank you for coming to this session. I'm a physical therapist and a laboratory scientist. I am practicing in New Orleans. I am in private practice, and I work in the last couple of my years in pediatrics. So my case will be on that.
And my name is Mary Shea Stifle. I am an occupational therapist. I work up in the New York, New Jersey area, and I've been practicing as an OT for 30 years and pretty exclusively in wheelchair seating for the last 28 years. Welcome, everybody.
Great. And if we were all in person, it would be awesome to actually have a show of hands of who you are and if you're working in this area or not. But since we can do some of this fun stuff on Zoom, go ahead and raise your hand if you're actively working with dynamic seating with your clients right now. Be cool to see. So we also would love to know if you have any specific goals, because we want to make sure that we're meeting those goals in this session. So if you have something really particular you want to make sure that we address here today around this topic of dynamic seating, go ahead and pop that into the chat box, and we'll do our best to address that as well. So we have disclosures here. Missy and Mary have no disclosures. I do, in addition to seeing clients and working with a number of companies, I'm in private practice. I do provide consultation and education for Seating Dynamics, who is a manufacturer of dynamic seating components. And here are our learning objectives, and we will do our best to meet each of these. And I see we have about more than 16 people who are working in dynamic seating right now. People are still raising their hand, it looks like. So this is what we'll be covering here today. We're going to talk about just what is dynamic seating. We're going to address the clinical applications, the primary ones of dynamic seating, and then we're each going to share a case study to show some unique applications of this intervention. And we'll finish up by discussing some of the limitations of dynamic seating, Please feel free to enter any questions or comments you have as we move along. If you're like me, you're going to forget otherwise, but we do want to hold answering any of those till the very end, so we make sure we get through all of this material. So let's start with just what is dynamic seating. Dynamic seating is movement which occurs within the seating system or the wheelchair frame in response to intentional or unintentional forces generated by the client. So this client is showing a lot of dystonia. A lot of this is unintentional, though she can trigger this when she would like to or is asked to. Other clients might actively seek out that movement. Dynamic components absorb those forces and assist the client back to a starting position using that stored energy. So dynamic seating refers to seating systems, wheelchair frames, and wheelchair components that move with the individual. Energy is stored, and that's what helps return the client to back to a starting position. And that might be stored in a spring, a hydraulic, an elastomer. And then movement typically is going to occur either at the hips, the knees, and or the neck area. So most seating systems we know are static, which would drive me crazy. I'm going to try not to be rocking back and forth during this whole session because my office chair allows me to move and I move all day long. But most seating systems that our clients are in are static. And if the client can move, they're moving in relation to the seating surfaces. So there's a lot of shear that's occurring. The client might stand up in their seating system. The seating system doesn't move. And as a result, the client often moves out of alignment. Allowing movement within that dynamic seating system or the wheelchair frame enables the client to move while maintaining contact with the support surfaces. That provides increased stability and again reduces that shear that the client might have otherwise. The individual's movement translates force into motion of a portion of that seating system or wheelchair frame and allows rather than limits or blocks motion of the client. Now, a lot of these definitions come from a resonant position paper on the topic of dynamic seating. We have a link to that towards the end of this presentation. It also includes a very comprehensive literature review of our available research. So what are the main clinical applications of dynamic seating? Well, dynamic components absorb and diffuse forces. So this can protect the wheelchair itself from loss of alignment, from damage, also can protect the client from injury. A lot of our clients who are very capable of actually breaking a component are going to experience huge forces to areas of their body, particularly through the joints, that can lead to injury. And we might see a decrease in active extension as a result. Another clinical application is simply to provide movement. Again, I like to move. Most of us like to move quite a bit. A lot of our clients actively seek out movement for sensory input, and this has been shown through research to increase alertness, decrease agitation, and increase sitting tolerance. And we also know through research that dynamic seating components may improve postural control, stability, and function. And you'll see some of this illustrated in our case studies. Oh, let me mute this loud video here. There we go. In this video, we see someone who is using a dynamic back on a manual wheelchair, and it's actually assisting her in her propulsion, particularly when she gets to the grassy area of the backyard. She's using the stored energy in the dynamic component to help with her self-propulsion. So dynamic seating components may be integrated within a wheelchair frame and can allow more than one type of movement, or these can be modular. And this is mostly the case in the United States, where these are either placed on a new chair or retrofitted to a chair and can allow movement in one or more areas, again, including head, trunk, hips, knees. And with that introduction, we're going to turn it over to Missy, who's going to go over our first case study.
Next slide. This is Oliver. I started seeing him around 3 months of age. He was born full term, but he was in a transverse or lying on his side position in his presentation in the birth canal. They did use forceps extensively for this. He was released after 24 hours and he went home, but within less than 2 weeks, I would say, the parents were having trouble with him arousing. And then when he did arouse, he was screaming and crying, and he was losing capability to feed, oral motor function at all. So they brought him into the emergency room, and they found out he was in status epilepticus. So he was having multiple types of seizures throughout the brain. It was so intense that they had to induce a coma to relax and try to develop a strategy with seizure medication to reduce this. It took a 30-day period in the hospital. Even when he came out, the seizures were still not under control. With that, they did an MRI. He had significant brain volume loss and parietal occipital subdural collections. They also did a barium swallow. They did not see aspiration, but he had a wetness to his vocal responses, so it was questionable. The diagnosis was cerebral palsy, spastic quadriplegia. He had an impairment of his cortical vision. He had hypothyroidism and a seizure disorder. Next slide. Play the video, Michelle. This is what he could do around 2 to 3 months. There was no use of his upper extremities at all. His shoulder extension was always pulled back, and what he did to lift himself was all with cervical extension. He was like a fish out of water, literally flopping around. I came in and I started instructing the family about how to bring the elbows forward of the shoulders to get him some leverage with his arms to lift his chest and his head off the surface better. But his tendency was always to draw it back. Even in supine, he did not bring his hands anywhere near middle. They were always against the surface. He had overall a low tone trunk with this active movement in extension all the time. That's how he moved in extension. He was having trouble with oral motor, but he could latch and suck the bottle. And over time, he's still on pureed to this day. Next slide. Around 4 to 6 months, they had him in an infant sitter, like most parents do. This one happened to be a rocker. And they happened to have him accidentally near the wall, and he started eliciting extension of his leg to rock himself. It was very intentional. As you can see, he hears the trapeze toys, and he sees them off and on. His visual tracking was very minimal. Even at 6 inches from his face, he would lose objects all the time, vertical, horizontal, any way at all. That did improve over time. By this period, about 6 months, he was able to prop on his elbows with assistance to keep him forward for about 5 minutes, and his head could be raised about 75 degrees. He was using his left arm at times to swat things. Right did not move very much at all. Next slide. So here he is around 6 months sitting. I could get him in sitting, but there was no riding responses, which you are seeing though from me intervening and the parents. He is getting a better alignment and control of his head, because his head was often rotated to the left and extended back. That was improving. So he was getting a midline orientation. He was able to sit a bit, but if he turned his head, he would fall over and there would be no response. No body on body riding, no hand being put out. If his left hand did go out, it wasn't fast enough or to be a response that could protect him. We also did a lot on the physio ball to work in transitions from back to side lying to sit to work abdominal work and anterior chest muscles. Next slide. So I realized this child, because he was very low tone and extremely weak, wasn't going to be sitting by himself. Maybe he could sit by himself by 12 months. I was thinking definitely not standing in developmentally appropriate time. So I started looking at, he was in a bumbo seat sometimes. And when he wasn't in the rocker, he was in a bumbo seat, but he was also by 8 months starting to outgrow that. So I was looking at standing frames and activity chairs almost back to back. So here he's in the standing frames, the one on the Gazelle ETAC and the Zing MPS by Easy Stand, as well as the Squiggles. I looked for all standing frames that had lower extremity abduction capability. Those were the 3 at the time. We brought him in, had mom set him up, fool with him. The other thing was the Gazelle and Zing were multi-positional, meaning you can get him horizontal, put him in because he was totally dependent, then bring it up to a vertical posture. So they chose the Zing MPS. Next slide. At that time when we were ordering it, this is what he'd do in standing without it. I had to support most of him, so it was at least moderate assist, but he still was trying to facilitate extension through his body by hyperextending his cervical spine, his head. That was still going on. I could get him in a kneeling position, but all of this required about moderate assist at the time. He was propping on elbows independently 5 minutes by 8 to 12 months of age. So that had improved. I also started seeing him spontaneously load his left hand and prop with it while he was in a sitting position. Constipation was still an issue, and that I thought about what I could do to assist with that. The standing was going to help that. It's been shown that it will help with digestion and elimination, but I also considered the activity chair for that. Next slide. So here he is in his first Riften activity chair with the pelvic support, which I really do like on that chair in particular. What I found this chair did for him, it allowed him to use that activity that he was from the very beginning used from birth, the spinal extension, but it allowed it to a functional degree and then brought him back to the position again. In Hahn's study in 2009, he found low-tone kids given a little low-level resistance increased their strength. I absolutely found that it increased his core strength. This activity chair absolutely helped him in his postural control, his eye-hand coordination, his head control, and his fine motor capability. It also helped with constipation, opening that back and then coming back down on opening your abdomen and then coming back and crunching helps move the food down the chain as well as the standing does. So both of those aided tremendously his constipation issue. The other thing I found is with the extension, you get better inhalation. So you have more volume, you have more air to pass through the vocal cords. So I found his volume and length of vocalization improved when he was in this activity chair or in a dynamic back. Next slide. This is the kind of things I was able to do with him by this time. He needed at least moderate assist for the hands and knees, and for the hands and knees, especially for the right arm. It was not getting extension actively at the elbow, and he often kept his right hand fisted, so I'd open it. But he was actively hitting toys, swatting at toys, buttons on things with the left hand, and attending to the toy and certain buttons with that hand. So that was definitely improving. Next slide. Around 2.5, he ended up fracturing his leg. And it was because of the extensor pattern that we showed. He was just showing throughout his development. He was still in a crib. They were in a small apartment. They were afraid to get a small twin bed for him because they thought he'd fall off of it. So they kept him in the crib, and they had double bumper pads around the crib so he would not get his legs through the slat. Well, he was able to one night, and he rotated extending from his belly to his back, and he did a spiral fracture of his femur. 8 weeks in the spica cast. When he came out, we again put him in the standing frame regime that he had been in a little bit before this. He had been using it 45 to 60 minutes at least 3 times a week prior to the fracture, and we put him up to 5 times a week after this. He was still not standing without moderate assist. And I was thinking, he did love standing. He did love the activity chair. So we said, let's bring in I had a Rifton walker that I just gave it to him to use for a couple of months. He did not, with me assisting a little bit when I had treatment with him, he did not develop functional gait through this. Also, he never, at times his limitations of his left hand was significant enough. We would, I thought about independent mobility. Back when he was 6 months old, I had a family in the area that has made bumbo seats with an axle and wheels on it. So I tried him in that. He could not use his right arm at all, and his left was very poor at positioning itself back on the wheel. So it really was non-functional for him. We also considered power for him, and the team that I work with evaluated him, and we did not find he could be consistent in his access of either buttons or a joystick or multiple things, as well as his visual awareness of the environment was very limited still with his cortical visual impairment. So we decided that at that time he could not do power, or he wasn't able to access and consistently do anything. So we went on to a dependent wheelchair. Next slide. Before I get into that chair, though, I wanted to show you a little bit about him. And yeah, if you could put that on with the volume. He loves music, loves musicals.
Alexa, volume up.
Okay, I think we can stop that. So he was definitely using this to get more volume and also to try to sing with music. He loved Mamma Mia, a particular song in that musical he absolutely loved, and he loved being in the activity chair doing it so that he could sing along with it. When he was on the sofa without the dynamic back, he could not nearly get the volume and length of vocalization that he can get in the activity chair. The other thing on the shot next to it, he did not put his right hand up. The parent did, but what you're seeing there is the upper trunk head control and the midline orientation, and his left hand is engaging with it. So some of that is misleading. He's not able to push that up and down yet. That's not something he can do, but he can hold on to it, which is something, and even maintain his balance while he's doing it. Next slide. These are just showing you, as the years went by, he's able to hold a marker with his left hand. He does scribble with that left hand with a marker. The right hand is not an assist. You have to put it on the paper. Okay. Also, you're seeing him activate his dynamic chair while he's out on the porch, and they have music playing in the background for him, and he's dancing to the music. The last slide is him with his ABC board, and he's actually able to swat and bang and hit, not always accurately, but multiple buttons on that board. Next slide. So here he is with the system that we decided to get him. It was a Freedom Designs NXT with their contoured seat, an open seat to back angle of 95 degrees. And we put the rocker back on by Greg Peak's seating dynamic rocker back. What I want, and he's also got an augmentation system they're just starting to try to use with him. Now he's about this was 3, but when this last shot here with the augmentation, he's 5 by that point. They had been trying, a speech pathologist has been working with him. I haven't seen him since he was 3.5 because he moved across the lake. But he has a speech pathologist that has got 3 different buttons, and he's not consistently using those yet either. But it's a way to start working on possibly power mobility at one point. But my point about the dynamic back, he did activate it, but not nearly as much as it has capability. There's several reasons for that, which we'll discuss because I don't want to take up any more time. We'll do it later when we talk about limitations. Next slide. This is just showing you him in the system. The next slide. In this group that I recommended, there was a private practice therapist I know across the lake. She does TheraSuit with the cage, they call it. This is a Russian therapeutic designed option. She is certified in it. There is 50 clinics in the United States that now use this. This TheraSuit was designed off of the Russian astronautic suit. It has cables in it with different tensions, so you can literally mimic with the TheraSuit, which now is patented in the US since 2001 and it's considered a soft proprioceptive orthotic. It has tensions in it, cables, small ones, all throughout the suit that can mimic oblique abdominals, erector spinae group. So literally you can help him trigger improvement in trunk control by the suit and how it fits him and the pulls on the tensions in the suit. But then you put it within the cage with the bungee cords and the different tensions, thickness, and like we talked about the elastomers, the hydraulics, in dynamic seating. Well, this is using it in rubber bandish or elastic cords that are attached to a cage. The cords can be pulled down towards the floor. You load the joints more effectively when you do that. But his lower extremities were pretty good by this time. He was still very weak in his trunk. So they were using the cables to set a boundary for him to dynamically try to find his center over and over again while he was in this cage. They also put him on a vibrator at times. And this last slide is showing you with him on the vibrator. So to increase, input to the bones, but also dynamically make him work his body more. Any questions you have on that, I'll be glad to give you some references to it if you email me. Thank you for this time.
Thank you, Missy. Appreciate that. Can you hear me all right? Missy, can you give me a thumbs up if you can hear me?
Yes.
Good. Okay, good. I want to make sure. All right. Well, let's go into my case study then. Oh, by the way, I'm sorry that I can't throw you chocolate through the webcam. So if you have some, go ahead and eat them. I've got a big one here, but this isn't an edible one at the moment. So we're going to talk about Daniel, who has cerebral palsy, and I've been working with him over a number of years. He has very high tone in his extremities, but like a lot of young kids, particularly with cerebral palsy, had very low tone in his trunk and neck. He also has seizures. He has cortical visual impairment like Oliver does, and he is non-ambulatory and non-verbal. So I work with him with his seating system and also access to other assistive technology, primarily to his communication device. So at about age 6, Daniel was in a manual tilt and space wheelchair with a linear seating system, and that's the picture you see here. He tended to extend at his hips. He extended against his head support, or his head hung forward. There was really no in between. He also, when he fell forward, would hook underneath his head support, which always gets everyone riled up. It looks pretty bad. His upper extremities tended to adduct, extend, and internally rotate, and his scapulars would be protracted. So if you can, here, I'm going to change the view here so I could see myself. You could imagine this sort of pattern kind of was what he would do over and over and over again. So this was primarily an attempt to keep his head upright, is what he was trying to do, is use that extension functionally. So our goal at the time was to reduce his extension by maintaining flexion at key points to kind of break up that tone. It didn't work too well, but we tried. By age 10, he had a manual tilt in space wheelchair. At this time, he probably had received a new one because of growth. He had a new linear seating system also because the growth had been exceeded in his past one. And he received a baclofen pump. And we really hoped that this would reduce his overall tone and help with our positioning, because we could only get so much done in his positioning system. But unfortunately, he had a lot of complications. Whenever the dosage was bumped up, his seizure activity would increase, and eventually he had also an infection. So because of these issues, the tone was greatly increased as a result of decreased dosage of the baclofen. We also added on a Stealth Products eye-to-eye head support. It helped the position of his head. It also helped prevent that hooking tendency. But over time, this huge force that he was exerting throughout his body with this active extension was starting to lead to a toll on his body. And I learned the hard way that our clients who are extending with such force can absolutely create injury to themselves. So he experienced a hairline fracture of the lower right femur. He had tendon tearing bilaterally below and lateral to his knees. Now, part of this was the force that he was exerting. He was also diagnosed with Osgood-Schlatter disease, which is characterized by these issues. And as a result, the orthopedic doctor who was working with Daniel recommended that we increase the amount of knee extension he was sitting in, because he was hoping that would reduce the force that was occurring through the knees. This is before we attempted any dynamic seating. So he would sit within his manual tilt and space chair, and his parents would shove a couple pillows behind his lower legs in order to prevent so much pushing. He was more extended, which helped to reduce his leverage, but also with these pillows, his feet were rarely actually on the foot plates. That meant he didn't have the leverage to extend with as much force through the knees. By age 12, the Kids Rock manual wheelchair was available. Now, this is discontinued at this time, but it had been a fairly recent addition to our options. And this really made a huge difference for Daniel. As soon as I became aware of the Kids Rock, I thought, I have a client in mind for this who has huge extension, who's breaking things on their chair and injuring himself. So the Kids Rock was an integrated system. You didn't add any dynamic seating to it. It came with the dynamic seating as a part of the system. And it provided movement at the back, at the hips, and at the footrest, primarily allowing extension at the knees. So this diffused tone by allowing movement. So we tried this out with Daniel. He really liked it. He did very well with it. He would extend frequently, but when he relaxed, he did come back to a more neutral starting position. He did have that underlying low tone in his trunk and neck. So when he came back, he kind of collapsed into this low tone, but he was staying in position in relation to the support surfaces. He was growing a lot by this point. You could see there's been a lot of growth already. Puberty was coming on strong, and we were really worried about his spine being at risk for developing curvatures. And so by this point, we recommended molded seating. We are very fortunate in our area, in the Denver, Colorado area, to have Aspen ride designs in our backyard. And so he has an Aspen seating orthosis. This is typically a one-piece seating system, but it has been articulated to allow for movement of the dynamic back. Now, by age 14, Daniel had continued growing. He did really well in the Kid Rock, but he outgrew the size 2, and the size 3 of the Kid Rock was really quite a beast. It was very wide, and the family, as much as they really wanted dynamic seating, just weren't able to manage it and returned it. So we eventually changed over to a more traditional tilt and space manual chair, and we added on modular dynamic components. So we ordered him a Quickie Iris with a seating dynamics, dynamic rocker back interface, and dynamic footrests. And behind his head, we had a Stealth Products tone deflector to allow for some force diffusion at his neck. So we then needed to keep in mind resistance. With dynamic seating, almost every option we have on the market has different levels of resistance. Well, to be honest, in the Kids Rock, Daniel showed so much strength that he was able to extend against the strongest springs and hang out there for way too long. So we were able to get from the manufacturer at the time an off order form, even stronger spring. So I assume that he needed the strongest elastomer we could get from Seating Dynamics. However, he wasn't able to activate this strong elastomer. I was quite surprised. So it's really important to check out that resistance. We went with the next softer, not the softest, but the next softer elastomer from the firmest. I believe that would be the medium. No, it would be firm because there's extra firm and firm. And that worked for him well. He was able to move it. And we didn't want the very softest elastomer because when we tilted the chair, that was enough to activate the back, that or putting a backpack on the back canes. We also adjusted the dynamic footrest at about 60 degrees of extension for his starting position. He was used to being in more extension at his knees by this point, really didn't have the range to start in more flexion. We also were able to rotate out the foot plates a little bit to accommodate some tibial torsion. And we put shoe holders onto those dynamic footrests. Most of our clients, if they're extending, will extend clear off of the foot plates and not activate the dynamic components. So we needed to use the shoe holders so that when he extended, it was with the dynamic footrest. So the problem was that Daniel is really strong. He was routinely breaking seating components and had injured himself. He had a baclofen pump, but it wasn't very effective because every time they raised the dose, it would allow his seizures to become more active. Again, here's a list of everything that had occurred without dynamic seating, the injuries that had occurred. Again, he had a hairline fracture of his lower right femur. He had dislocated or ruptured, both his patella. He had dislocated both of his elbows, and his knees were always red and swollen. Now, a lot of the time, because of this low underlying proximal tone, he could look like someone who didn't need dynamic seating at all. But heaven forbid you had your hand under his thigh when his tone shut off. I needed help getting my hand out. But since he's been using dynamic seating, he has had no new injuries. His knees are no longer red and swollen. His family will say we will never, ever have a static seating system again because they see what a difference it makes for him. He's been using the dynamic rocker back interface and footrest for a number of years. Here he is on his adapted baseball team, and he's very extended because he's running to first base and, well, actually, probably home if I'm looking at this picture right. So he's very, very excited, and this allows for that. He does relax down into his seat. So this is his starting position. This is his starting seat to back angle and his knee flexion. But again, he can extend as needed. So I'm going to show you a video here of Daniel when he's watching his favorite thing on TV, Rockies baseball.
Just kind of went into the countdown, and it was like,
So very excited. He can extend as needed, but then return to that neutral position. And with that, I'm going to hand it over to Mary for our third and final case study.
So it's a tough act to follow. I mean, we had Oliver and Daniel, they're absolutely gorgeous, but Tamara is pretty adorable too. And you can see the only thing with Tamara is because of COVID, you're not going to be able to see her spectacular smile, but you could see some of it through her eyes, which is really fun. So Tamara has CPs with spastic quadriplegia. She has dystonia, scoliosis, peripheral vascular disease, lower extremity edema, some impaired sensation. She's very sensitive to temperature changes. And in the last 4 or 5 years, she started to have some issues with right DVT in her upper leg, significant hip pain, and also lumbar spine pain, and was going back and forth to orthopedists, et cetera, to help work with some of this. And so she had been in multiple tilt and space wheelchairs throughout her life so far. And I had seen her when she had a custom molded contour U seating system with a chest harness. And she was having a lot of issues in terms of constant breakage of the footrest components. She previously did have dynamic footrest, but that was changed by a therapist somewhere in between. And I don't know if it was for funding issues or whatever, but we'll get into that. But here she is in this presentation with a headrest which also has a lateral facial pad there that you can't really see with her dark hair. But I thought it was important to be aware of what she's currently sitting in at this point. Biggest issues for her family was the time that she was out of her wheelchair because of breakage of different components, and just the time it took to get repairs completed for her. And it resulted in sometimes her parents needing time off of work, but also her being out of her day program or out of school when she was younger. Next slide, please. So when I saw her, she was in it was actually a 15-inch wide seating system. We just realized that's a typo. And the clinician at the time thought, hey, you know, she sits pretty symmetrical. I don't know if she really needs this custom contour U back support anymore. So they went to like some of the newer off-the-shelf products, because now we had products that were available for that. You know, back in about 6-7 years ago, we started to see a lot more options in terms of back supports with different lateral contours on there and different options. And so they had transitioned to more off-the-shelf seating with a pressure distributing cushion. And one of her biggest challenge was that she loved the way she looked here, Tamara. She absolutely loved it, but she really couldn't tolerate it. And apparently she just needed a lot more accommodation for some of her difficult to correct and non-reducible deformities. And then at the same time, then she started to have over 2 years a 40-pound weight change, which was significant. And it warranted then that the whole chair was not fitting her properly. And she ended up with pressure from the on her lateral calves from the actual footrest, the upper assemblies of the footrest. And she ended up with that DVT that we spoke about from the underneath the cushion on her legs. Next slide, please. So you can imagine, her and her parents' concerns were a lot of the discomfort, the joint strain, inability to tolerate sitting in the chair, the constant breakage with the headrest and footrest components. She was, frustrated with it, so there was more agitation. And we were looking at a new chair. And so she really wanted, the chest harness and some of the components. And I was always worried about, are we overcorrecting her? And is that also contributing to some of her agitation? Or I'm not, sorry, we're not overcorrecting, but over supporting her with all these straps and stuff. And is that contributing to some of her agitation? So I was being really careful about how we were ordering these components and adding them on, and starting with some stuff and then adding to others. So what I mean by that is, like, I would start with the back support and the cushion and the seatbelt first, and then, do you really feel you need that extra support for your chest? And then the answer was yes. So in the end, what we ended up with doing with her was that the wheelchair wasn't old enough to warrant a complete new frame. But what we did was we were able to grow her frame because it was a quickie iris, and we were able to get, new cushion, new back support. And because of all her issues with her hips too, and she was having issues as well now, which was really interesting, with just redness on her buttocks from sitting. And so we tried numerous cushions at home. And, I don't often feel that you can't make some of those decisions in the clinic. She needed to have these products in her home for an extended 2-3 week period of time for her to make the decisions on this. Because even though her sensation was impaired, she had sensation and she could feel pain. And so, and discomfort. And so we gave her a host of cushions to try all different mediums to see what she would prefer. And in the end, we settled on it ended up being a fluid cushion, a gel J2 deep contour cushion. We also ended up doing, we went back and forth between what dynamic components, and we ended up doing not a dynamic headrest or a dynamic back for her at this point. We ended up doing this stealth headrest with non-flip down hardware, because the flip down hardware, her history was, it was just too much give there, and it was frustrating for them to rely on that. And she didn't feel so stable with it. And we ended up doing a smaller pad, but for the cover for that, we used a reverse Dartex so that it wasn't constantly pulling at her hair, because she was often using her head and going into extension with that. And when it had a different material, she would feel it was pulling her hair. And so for the chest harness, we actually went to the Body Point Stay-Flex anterior chest support. And that has some nice stretch construction up on the top there that allowed her to have some ability to reach and to move, but it also gave her a good feeling of stability. So that was a key component for her personally. And then because of her issues with the lateral calf and her lower extremity positioning needs, we ended up doing offset hangers actually on the footrest to get them completely out of the way. And that gave her and her parents a big comfort level, because they were really upset with having the DVT and that, and then the indentations in her lateral calves when she did gain some weight there. And then lastly, for some of the what dynamic components we would use for her was the Miller dynamic footrest extension tubes. And so we used their dynamic coil spring suspension there in the tubes, and we used the L-shaped tubes to allow for optimal footrest height and just the way the excursion was when she was actually using them. Next slide, please. And so you can see then once we were fitting all the different components with her, I was telling you how we did it, in a stepwise process. And so here we were with the footrest, and really looking at what happens when she was going into extension there, and how much recoil was there, how much play, and then what did we need any additional footrest support there? And so we did order and have the shoe holders ready, but I wasn't so quick to put them on. Her feet surprisingly stayed okay on here, but I don't know if it would have lasted in the long run without the shoe holders. Something else I actually forgot to mention for her, which was a little tricky too, was she had a leg length discrepancy. And that was really challenging just to get the footrest up high enough with the dynamic coil suspension component in there as well. So that was something that we had to, we worked on early on when we were specifying the equipment. Next slide, please. So as we watched her moving, we were really taking a look and seeing what was happening with her legs. And yes, I could easily push, put her leg into a neutral position. But really her preference was for that left foot, and slightly slow on the right side as well, for that slight toe out position, because there was some tibial torsion going on there. And so when we did the final positioning on this, we actually left it with her foot toe out so that we weren't putting unnecessary or weird forces on her knees as she was going into extension there. Next slide, please. And so you can see up close, once we get the footrest on, you can see the actual play there. And unfortunately, I didn't take a video of it, but I think with the videos that of both Oliver and Missy from Oliver and Daniel from Missy and Michelle, you can see how these components actually work. And it really is, it really makes such a difference for our clients. And so next slide, please. So basically overall, she had a significant increase in sitting tolerance, was able to now tolerate going up to a full day of active sitting for her. She had good alignment and good postural support. She felt enough postural stability that she's able to go back, and she doesn't have a lot of functional movement, but she is able to feed herself some finger foods. So with that, the harness and with the support from the Contour U custom mold, she was able to go back and start doing that again and be more active in that. And just being able to sit in her chair and be out there and not have all the pain, it really helped her just to, one, minimized her fatigue, and two, it just increased her alertness and her ability to participate. Now she's able to go out to more family events and be more involved again. And so the footrest components really made such a difference with that. And her parents felt very strongly from their history with it that, how it made such a difference in terms of the durability. They had that test of time. And, there was a newer therapist somewhere involved, and, she thought, hey, maybe it was too expensive or whatever. But bottom line, it was, this is really money well spent, because the durability for this and the lack of constant frustration with components breaking down was resolved with the dynamic footrest component. And so if we go to the next slide, you can just see Tamara sitting from the front there. And bottom line is increased sitting tolerance there, increased participation, increased her satisfaction, her parents' satisfaction with the equipment, and she didn't have to be repositioned as much throughout the day or need to come out of the chair as much. If we go to our next slide. So I think when we look at all the dynamic seating components, you often hear that they're so much more expensive, and that why do we need to go there, that because of the expense. But quite honestly, there's such a significant cost savings with the dynamic components. It's just an expense up front, because what happens is you have such a significant difference in terms of repairs and broken parts.
Absolutely.
And for the caregivers and the families who then have to try to come up with parts, and it's a lot of extra time and energy and frustration when the chair isn't usable by the client because they can't sit in it because they're not getting the support that they need. And so, and never mind all the other indirect costs. And you've heard that with some of Michelle's, with her presentation with Daniel, with the different medical procedures and stuff.
Sorry, that was me.
Okay. With the the amount of medical procedures, from like what was going on with that, with the actual quadricep pulling the bone off. I couldn't imagine the pain that he had. And yet it was a movement that he needed to keep doing because that was what was happening with his body. So just unbelievable. So the cost of the injuries, the pain, the frequent repairs, and also the cost of clients or these people missing school or work or their day programs, and their families missing programs because then they are not where they're supported during the day. And so there's a lot of indirect costs there as well. In addition, we have another slide on limitations. And so that I think addresses the cost, but sometimes the hardware can be too bulky or too resistive. And you heard Missy talk a little bit about that with Oliver. And she was saying that, maybe she needs to look at something else there. And did you want to speak a little more on that, Missy? Or
Yes, Mary, thank you. This is where I wanted to bring it about Oliver's chair. Oliver is only about 25, 28 pounds at 5 years of age. Also, with pediatrics, you have a smaller amount of real estate to deal with all these pieces and parts you're putting on a frame. So to put the seating dynamics hardware for the rocker back on there, it also affected where we could put the attachment for the armrest. So if you noticed in that photo I had, his armrests were too high, but we had to do that in order to put the dynamic hardware on there. The other thing is growth in pediatrics. So he had 2 inches, the seat to back angle, his seat back and his back and his seat angle was 95 degrees, but he was 2 inches forward of the back cane where the dynamic hardware is. You following me? So also the back cane and rail were 90 degrees. So there were a few things that weren't congruent to make, so it could cause impingement. So we're in the process of rectifying that with the equipment supplier, who's excellent, and with Greg Peak involvement. Also, like they both said earlier, Mary and Michelle, the elastomer, I think he has a medium on there. He really needs the lowest, lightest he can get because of his size. The last thing I want to bring up that Mary brought up in her case study, Oliver's parents, because he had such limited movement, did not want his feet in shoe holders. So we used a padded strap across the lower ankle, the lower leg, but he could still slide forward. So some of the force that would have been generated into the back went out forward on the feet. So that also affected how effective this back could be for him. So all of that needs to be considered. Weight of the child, the real estate of the frame. Can you put everything on it in the position you need it to be on?
I'm going to interrupt real quick. We have about 5 minutes left, just so you guys are aware.
So I'm
Yeah,
going to
why
finish
don't
up.
we- Yeah, we
quickly
can move
with
ahead to
limitations. But
our
I think you
take
got
home.
and I think you got the gist of it with the limitations, that there's always growth changes and you always need to follow up and make sure it's doing what you expect it to and do the maintenance and repair. So I think everyone got the gist as well of, like, there's tons of benefits to dynamic seating. It's just another tool in our toolbox. And just just not to forget about it and just know that it exists out there, and it works really well for certain clients. So I know we put a few handouts out there. Michelle has an amazing decision-making tree that looks really cool when you go into it and just start to work through it to help with trying to figure out where does dynamic seating fit and is it maybe appropriate for a particular client. But we also have the position paper and the PowerPoint. So there's a bunch of questions that are in the chat box. So
Yeah,
we want
we
to
have a
give a
lot.
few minutes for that. Yeah.
Yeah, let me move the chat box over where I can see it. So I'm just going to take a crack at some of these. We can all jump in. So Teresa has asked Missy, on Oliver's case study, is he standing on a Galileo for vibration?
Yes.
Great.
Yes.
And Lisa has asked, what are you using these days in place of the Kids Rock? Basically, like with Daniel, just other brand chairs, depending on whether that client needs tilt or not. A lot of the clients I work with who need dynamic seating also need a tilt, and then we add on retrofit or order with a new chair the dynamic components. Someone else has asked, Melissa, I have a 17-year-old student who has broken through the quickie pin system on the backrest twice and the Seeing Dynamics backrest bracket and shears off bolts on leg rest using dynamic spring coils. Ooh, same issues with backflip
Wow.
pump. Any suggestions? Wow. You know, it's amazing the forces our clients have. What I would suggest on the Seeing Dynamics backrest that you look at is the firmest elastomer in there? Is it worn out? These elastomers need to be replaced periodically, at least once a year for a lot of the clients, because that's the area that takes the hit instead of the equipment breaking. So you change the elastomer. If the elastomer is worn out, the two metal sides of that backrest bracket can touch, and then it can break because the forces are no longer unrelieved. So I would check that. And if you're still having issues, definitely reach out to Seeing Dynamics about that so they can address it. If bolts on the leg rests are shearing off when you're using those dynamic spring coils, you know, the spring coils are designed primarily, the Miller spring coils, to rotate. They'll also telescope somewhat. So it might be that depending on your client's movement pattern, where the force is going, the best way to determine that's really to get them out on the mat table, sit behind them, see where are those forces shooting off. It could be that the back isn't absorbing the forces the way it should if it's not moving correctly. And so that can translate to more force on the footrest, but you might need a different type of dynamic footrest that can capture the movement in a different way. So for example, the Seeing Dynamics dynamic footrest will telescope, but it will also extend, and there's even potential ankle movement. Another question here from Access Therapists is, have you been able to make the Seeing Dynamics dynamic footrest work with lower limbs with severe asymmetry? My client has a left leg with 15 degrees internal rotation, 10 degrees abduction, I'm trying to see this in my head, with severe tone and extension. Can the leg rest accommodate positioning like this? You know, I'd have to look at it closely, but the Seating Dynamics dynamic footrest probably have the most hardware options and the most adjustment to accommodate an atypical foot placement in general. But I would suggest you contact Seeing Dynamics too, and maybe show them some pictures of your unique situation, and they can let you know what hardware would be required. And I've been answering too many of these. So Missy and Mary, would you like to take on for what other diagnoses besides spastic cerebral palsy have you successfully used dynamic seating? And before you answer that, I'm sorry, just because of the time, if our moderator could, oh, I see the CEU code. So the CEU code is in the chat box if you need it.
I can speak it real quick for everybody.
Okay,
Who doesn't
great.
have chat. The CEU code is VTHPCN, and it is also in the chat box. And we can continue on for those that want to. I think we don't have anything else until 2 o'clock, so feel free to continue the discussion. I'll be hanging out here in the background.
All right, thanks.
Well,
Mary or Missy?
Regarding the other, diagnoses I've used spastic, dynamic seating on, Oliver was diagnosed with spastic quadriplegia CP, but he really, he has spurts of spasticity or extension, but he's really a low tone kid. So I wouldn't, CP's one, but you could use it on low tone as well as spastic athetoid, dystonic CP. I could use it on people with head trauma. I used to use extensively. This is how I got into dynamic seating. Miller hardware was one of the first ones that started trying to figure out how to prevent this breakage. I started seating in 1984, stainless steel, everything. And I had kids and adults, particularly head trauma, snapping stainless steel back canes and front rigging constantly. I mean, continuously. So I had to look for something that could help with that movement and also prevent damage to the frame and the client in it. So head trauma was a huge one that I know a lot of people use it. ALS, Huntington's chorea. I mean, there's
Yes,
just,
definitely.
tremendous amount of people that need it with that. Anybody else want to add on to that?
No,
Mary?
I think that, no, I think with the brain injury, that head trauma is huge population, absolutely.
Yeah. And then I also see some clients that now many of them do have cerebral palsy, but I'll just need to move. They just want to move. And there may not be a tremendous amount of tone there.
Let me just say one other thing.
Mhm.
I would say, I know I do a lot of sensory integration cases. Kids that have high threshold tactile and vestibular, they can't sense things as easily as your eye, but they are craving it. So they'll bang, bang, bang against the back or the pound the footrest. And if you give them that motion, lots of that goes away and it gets much more focused in what they do. At first, they might exacerbate on it, but then it starts calming down. So they're craving movement because they don't have the sensory profile to feel it as easily unless it's intense, the stimuli. So they're banging against the back tactily for that stimuli, as well as the vestibular head motion back and forth. So they're getting more aroused and more attentive, and then it reduces once they get what they need, and they can get more functional because the sensory is there for them now to be able to use in a more functional way.
Sure. We have a two-part question here. We have a lot of questions, so if we could just try to answer this briefly, and we're very happy to follow up with anyone too. The second part of this question is, are there dynamic components that change in force that can be provided given the day and the student needs, or are you stuck with just one? So I can answer that one. You do have to pick a level of resistance, and we do have clients that vary a lot day to day. So what I try to do is find a level of resistance that works for them over those fluctuations as much as possible. There is a range of tone that each level of resistance can seem to handle, and that usually works well for my clients. And then the second part of this question is, would you recommend considering dynamic seating for kids with low tone to provide some movement? You want to touch on that one briefly, Missy, since that's similar to Oliver's situation?
Well, I would say this, if they are just low tone and don't have that, Oliver did this dynamic, initiated it on his own, full extension pattern. So I tried to, because he wasn't doing much else actively, I tried to capture that and use it in different ways, and it did end up helping him tremendously. If you just have a low tone person that is not able to do any kind of movement like that, I don't think dynamic, you want them to have the capability to move, but I don't think the issue becomes, can they activate the back with the lowest elastom or hydraulic or spring? If they can't engage it, then it's just more weight and not useful, if that helps to answer the question.
I think that's a good answer. Maura has asked, for dynamic headrest applications, how do you address safety for transport and head support? It's an important question. I actually wrote a blog just on this topic on the Seating Dynamics website. So I'd recommend that you check that out just in interest of time. But very important question. Carrie has asked, have you found a seat to back angle trend that seems to work best with the dynamic seating when hip range of motion limitation is not a concern? I can take a shot at that and then love to know what you and Mary and Missy think. I think that the seat to back angle, I'm still pretty much looking at what works best for that individual's posture. And then I add on the dynamic seating from there. Missy and Mary, do you have
That's
any?
exactly what I do too, Michelle, exactly.
Yeah.
No, there is no set, it's individual for me, what works for that individual.
Yeah.
And I haven't used many dynamic backs at all. In fact, none at all.
Okay. Someone else has asked, Melissa, have you ever used dynamic rocker back bracket components on a ride design custom mold back? Yes, I have. I've used dynamic seating quite a bit with people who use molded seating, and actually works really well. I think for a lot of people with a lot of extension, there's often a concern about shear when we have a molded back, but my clients are getting so much shear by moving out of relationship with the support surfaces without dynamic seating that shear is usually decreased.
I would agree with that too, Michelle, absolutely.
Yeah, and then someone else has asked, what are your thoughts on using elevating leg rest to help reduce the tendency of pushing into extension and avoiding whole body extension? When you guys want to take that one on?
I think that has to be individual. Like, Michelle mentioned earlier, when I'm doing a chair, I'm looking at how the child or adult's moving. And I'm trying to do what I can if I'm trying to reduce this full pattern of extension, where is it strongest? Where is it? It's almost, I've seen, especially with dystonic, there's a sequence of events that occur. And so where is it initially occurring? Where do I need to maybe put like, for instance, if it's at the hip, do I need to do, hip reduction of hip flexion? Of hip extension through increasing hip flexion. And then is it more coming from, then the next thing I might have to do is the knee. Other people, it starts at the lower leg, or it could be at the head. So whatever is the initiator, I look at that. What can I do to reduce it? Now, how does it affect the rest of the extension pattern from the intensity and the degree in which they can do it? So I do it segment. Really look at them, each piece and part, and how it interferes with the whole, and try to address the most severe part, and then see how it impacts the rest, to know where the angles of the seat back, the knee to the seating system need to be, the front rigging to the seating system. So it's not one size fits all, I guess. I really look at how they do it and how it progresses.
And I would just add, it depends on that person's available knee extension. I have a lot of clients that have very tight hamstrings, and with some of these dynamic footrest options, you can order it so that there's a telescoping movement rather than just knee extension. And sometimes that still diffuses the force and allows some movement without pulling this person's pelvis out of position. Curie has said, have you had success with access to these dynamic components to trial before locking in an order? The challenge with a lot of these is depending on the component, sometimes you have to modify the frame to put it on. So it's very hard to try it out. But I think there's a lot we can do on our mat assessment to get a sense, kind of like what Missy was just saying, about where is the force coming from? When I move my body in response to the client's force, am I seeing a difference? And that helps me determine if a dynamic component will be helpful. Again, I actually, on the Seeing Dynamics site, did a series of videos in how to determine, without trying actual components, whether a dynamic back, dynamic head support hardware, or dynamic footrest might be helpful. So I hope those might be helpful to folks as well. Kristen has said, anyone aware of options for power wheelchair users with spinal cord injuries who have lower extremity spasms and need dynamic footrest support? A lot of the dynamic footrests that are available, at least in the United States right now, are pretty much from Seating Dynamics and Miller's. And some of those will work on power wheelchairs. Where we usually have a problem is center mount, the center mount footrests that are so common and so awesome on power wheelchairs. There's a lot of nice advantages. Those aren't generally compatible with dynamic footrest. And then Russell has said, why would you not use the dynamic back that Sunrise makes for the Iris? Definitely, Missy and Mary jump in on this too. In my personal experience, I've had some clients, of course, I'm using this dynamic backs with someone usually who has a lot of force or a lot of constant movement throughout their day. And I have had clients in both those categories who have absolutely destroyed the Sunrise dynamic back. I have spoken with Sunrise about this, and I hope it's something that is improved, but I find that it is not durable enough for my clients that are already breaking things on the chair and injuring themselves. Do you want to add anything?
I have not used the Sunrise, but I have used Miller and Seating Dynamics, and they both have worked for me with head trauma, which is some of the higher tone kids that are sustaining the extension.
Yeah.
All righty, guys, I may have to jump in and we'll have to shut her down. But thank you guys so much. This was
actually
wonderful.
I think we got them all. So
perfect.
Yay, apparently.
Thank you, everyone.
I wanted to give you guys as much time as you could because that was
No.
a great discussion. So thank you guys very much.
Well, thanks to everyone for sticking around who did for the questions.
Thank you very much.
Awesome.
Thank
All righty,
you.
guys. Thank you very much.
Bye, everyone.
Bye. Enjoy the rest of the conference.
Good job, Mary.
Great job, you and Missy. Wow. It's a rich topic, and it really is like just doing the case study